Thanks for your patience, everybody. I'm Andrew Reeve. I'm the Chief Revenue Officer for CoachCare MD Revolution. I'm excited to introduce Dr. Sieck, our Chief Medical Officer, and Paul Huffman, our VP of Client Services, to review a case study on readmission avoidance for heart failure patients using remote patient monitoring and chronic care management. So, Paul, Dr. Sieck, please take it away.
Thanks, Drew.
And as I was saying, this timely for next year. There's a lot of changes coming with CMS payment models, but also some regulation changes. So it's really important to focus on the outcomes and some of the clinical data that we've been able to show here at CoachCare MD Revolution. So, Dr. Sieck, if you wouldn't mind introducing yourself briefly, and we'll go ahead and get started.
Thanks. I'm Teresa Sieck. I'm the Chief Medical Officer here at CoachCare. I'm really excited to unpack what is truly one of the most compelling heart failure RPM outcomes we've seen in this field. I'm excited to also kick off the first of a series of office hours. I'll be hosting with learnings and evidence like this and a chance for dialogue with our current customers, as well as other folks in the market that may not be our current customers, but really want to learn about best practices in our space. So again, we appreciate you joining us today, and we're excited to share our findings.
Great. Thanks. Thank you, Dr. Sieck. So today, what will we cover and focus on? Our roadmap today is really to focus on what MercyOne's challenge was and how we were able to put together this 450 patient advanced heart failure cohort, the actual workflow and the design that was put together, and the interventions that took place, and why this program delivered remarkable results: zero readmissions for MercyOne. And we'll also look at some other comparison and similar programs. We have a couple of studies within cardiology and heart failure and readmissions, working with not just RPM, but RPM and chronic care management included. And then also a quick look at next year's fee schedule, CMS fee schedule, and why these changes are positive, and some of the new payment models for next year. So the MercyOne Heart Center, what was the problem and what was the challenge overcome? They manage currently over 9,000 heart failure patients, and their advanced heart failure patients, their sickest of those patients, were experiencing preventable high frequency readmissions. And so, Dr. Sieck, from a clinical lens, what is unique about advanced heart failure patients?
Yeah, the thing about advanced heart failure patients is they can destabilize very quickly. So we're talking about your stage C and D structural heart changes and your New York Heart Association functional class 3 and 4. So these are more advanced heart failure classes. And really quickly, these people can decompensate. 1 or 2 pound weight change, shift in a blood pressure or heart rate can really predict that serious event. So these patients really need tight, proactive intervention, not the reactive model hospitals are forced really to work under currently. So just a new look at how we manage some of the more advanced heart failure patients.
Great. So why continuous monitoring? Why is this important? Remote patient monitoring, continuous monitoring. We're not just talking about adding more data for the sake of data. We're talking about addressing a real physiological volatility in the advanced heart failure population. So these patients can look stable at 8 a.m., but then there's a dangerous fluid shift later in the day, right? So these are incremental changes throughout the day. So these small variations, don't matter maybe as much in some other chronic diseases, but can really add up and become a tipping point in heart failure. Even 1 pound of weight increase or a subtle BP trend change or a missed measurement, this can signal coming decompensation that traditional cadence just won't catch, just in the office. So it is really important to be monitoring these patients, not just when you're seeing them in the office, but when they're at home or not in the office during a visit. So this is exactly why patients end up back in the hospital, right? So 1 in 4 heart failure patients are in average are readmitted within 30 days. So this is huge penalties for health systems tied to compensation for those readmissions, and this is a growing patient population that is affecting over 6 million adults in the U.S. So it affects patients, it affects our system, and it also affects cost as well.
Yeah, and the important thing here is that decompensation is rarely sudden, right? It's usually detectable if someone's watching closely enough. The problem has never been the lack of signals for these patients. It's been the lack of continuous clinical eyes on those signals. So that's where the gap has been, and that's where continuous monitoring really fills that gap.
That's great.
So one of the very intentional things that MercyOne made at the onset was the start of their sickest patients. We talked about that briefly just a second ago. The stage C and D patients, the New York Heart Association functional class 3 and 4, they didn't start with the low acuity convenience cohort. The structural A's and B's and the New York Heart Association functional class 1s and 2s, they enrolled the more advanced heart failure patients. We put in 450 of these patients that were being followed by their advanced heart failure team. And that was absolutely the right call. These are the patients who destabilize quickly, who often present to the emergency room before anyone even has a chance to intervene. Even a 24 to 48-hour delay in recognizing a fluid shift can mean the difference between staying at home or a hospitalization. So when we evaluated MercyOne's baseline, they were dealing with an 18% 30-day readmission rate in this specific population. Not because the clinicians weren't doing the right things. It was because the data was fragmented, the escalations came too late, and the patients were very limited in their engagement between visits. So the key there is really trying to identify where those gaps are and really try to drive meaningful interventions. So it's very important once a patient has left the clinic that they receive that continuous visibility, because that visibility was not happening on a day-to-day basis prior to us implementing this program. That's when our clinical team came in. We handled the daily reviews, the vitals and symptoms. We looked at trends as well as those isolated triggers, but more importantly, knew the patient well enough to identify whether there was any patterns or trends happening. And our job was to recognize those subtle signs, the early instability signs, and bring those forward to the clinical team at MercyOne as an escalation and that an action was required. We worked directly with their heart failure specialist for rapid interventions, providing clear documentation and context so that they could make timely decisions in the care plan, make medication titrations, or schedule an office visit same day if needed, just to avoid an emergency room visit or a hospitalization. So this partnership allowed us, along with the specialty clinic, to stay fully focused in our lane. The clinic was able to stay focused on managing the patient while we maintain focus on that clinical oversight between each office visit.
Yeah, I think that's really an important distinction, right? Is getting the teams to play their role and doing it well. And that alignment between the teams, the patient cohort is really what led to these results in the program altogether, right? So a dramatic reduction in readmissions, catching fluid changes earlier, supporting the heart failure specialist team within the hospital, and ultimately keeping these high risk patients stable. And starting with the sickest patients doesn't just make sense clinically. It accelerates the impact of the results, right? So the program demonstrated what early detection can truly accomplish when everyone's on the same page.
Yeah, exactly. So one of the most important elements in the program was a workflow discipline between our clinical monitoring team and the MercyOne advanced heart failure specialist. Here's how the data entered the system and became part of that predictable clinical pathway. First, patients recorded their daily vitals using connected cellular devices. So weight scale, blood pressure, resting heart rate. There was no pairing of devices, no app navigation, no manual steps. Once a measurement was taken by the patient, the data transmitted automatically. From there, the CoachCare clinical monitoring team reviewed every patient's data each morning. So in this structured fashion, we were really be able to identify what was going on with the patient. We weren't really chasing alerts. We would identify those alerts, but we would also look at the trends and try to determine whether there was a pattern that needed some clinical intervention. We look for directional changes, fluid accumulation, blood pressure variability, heart rate variability, and even missed readings, as that might signal any behavioral or clinical concerns. When we identified something that was meaningful, that's when we escalated directly to the MercyOne Advanced Heart Failure Specialist with clear documentation and direction, what was going on with this patient. And once the specialist team received the escalation, here's where things started to roll, right? This is where they made timely medication adjustments, timely diuretic titration, and or brought the patient in same-day visit to help prevent those ER visits or hospitalizations and or readmissions. This integrated model worked because each team, as I stated previously, stayed in their lane. CoachCare provided that continuous clinical surveillance and oversight, and MercyOne provided targeted clinical interventions. That alignment is what made the program operationally strong and clinically impactful.
Yeah, I think, again, just to highlight that we see this over and over again, right? Technology doesn't just solve this problem. You need to have the clinical teams focused on their lanes and what their roles are in this workflow. But the workflow and having everyone on the same page is what the multiplier is to really make these successful, right? So you have clear roles, you have consistent review, rapid escalation, like you mentioned, pathways, and the outcomes are changed dramatically. The results are amazing.
Yeah. And so once that workflow is in place, the next question becomes, what exactly are we watching for every day? So for advanced heart failure patients, stability isn't about just a single outlier value. While we're looking at that, we're also looking, as I stated, at patterns and trends. So every morning, our clinical monitoring team reviewed several high fidelity indicators, weight changes from dry weight, especially anything that's trending upward that would suggest fluid retention, monitoring blood pressure, not just highs or lows, but patterns as to when blood pressures might fluctuate, heart rate fluctuations, as a lot of these can precede symptom escalation. So prior to the patient even saying they have symptoms, we can start to see some of these vitals start to shift. So starting to see trends or patterns. And importantly, patient-reported concerns or symptoms. So when we're looking at these vitals and identifying whether there's any new patterns or trends or a direct alert, we want to gather if the patient's starting to have any symptoms and whether they need to be escalated. So this is where the human touch comes in, where we're collecting through technology the physiological readings. We then put the human touch on to gather whether the patient, how they're functioning in their home and whether they're having any symptoms. And we do this through direct touch points. So we're actually visiting with the patients telephonically to make sure that we're really understanding the whole picture of what's going on to them as we're looking at the vitals come in. All of these inputs create a much clearer picture of how the patient is trending, and most importantly, how likely they are to decompensate.
Yeah, so all those early signals that you mentioned, right, made all the difference. Is the clinical team plus the technology and the way that the workflows were established. So we see this is a situation where a small diuretic adjustment at 10 a.m. prevented what absolutely would have been a hospital readmission 6 or 8 hours later. And so again, can't emphasize enough, or it's got to be the teams, the workflow, the clinical connection between heart failure specialists and in this case, CoachCare with the aid of technology.
Exactly. That's the power of continuous oversight, because our team was able to flag these issues early, and because MercyOne heart failure specialists responded quickly, we were able to prevent exacerbations before they ever reached that point of instability. So this wasn't reactive care, it was proactive, daily data-driven clinical surveillance. And that's what ultimately led to the dramatic reductions in readmissions.
Yeah, that brings us to the headline of our whole discussion today, right? What were the results and the outcomes to everything that we've described up until this point? Could you really focus in on what the magnitude of the outcomes and what we're looking at?
Yeah, for a patient this clinically fragile, zero readmissions really is almost unheard of. So these are, not mild heart failure patients. These are 450 of the most advanced heart failure patients, the sickest of the group that MercyOne was managing. And they had an 18% 30-day readmission rate. Statistically, a large portion of them should have been returned to the hospital within weeks after enrollment. But what happened here is that early intervention consistently interrupted that progression towards decompensation long before symptoms became severe. So when our monitoring team saw weight creeping up or subtle blood pressure shifting in the wrong direction or resting heart rate elevated, those weren't just brushed off as small fluctuations. They were escalated immediately with context to the MercyOne heart failure specialist. And because the specialty team responded in real time, adjusting diuretics, reinforcing medication adherence, and bringing patients into the office for same-day visits, those exacerbations never reached a point of crisis.
Yeah, and that's exactly why you see these outcomes, right? 81 readmissions prevented, 26 clinical care gaps closed, medication adherence improved significantly, and a complete drop from an 18% readmission to 0% readmissions within the first 30 days. So this just is phenomenal. These are phenomenal results for a really high risk population.
Yeah, and the part I want to emphasize in this is that, this was not luck. This was methodical implementation, consistent monitoring, and rapid specialty intervention. So we saw measurable results within months. And when you put the right system around advanced heart failure patients, the data speaks for itself.
Before we move on to 2026 and some of the new models, I really want to show a similar cohort that we saw with another cardiology practice um, and how that affected readmissions, all readmissions, not just heart failure patients, but at a large clinic, Cardiac Solutions in Arizona, we looked at a much larger cohort. It was actually over 26,000 patients over 12 months. And what we saw was even surprising to us. We saw a directional impact. Uh, we took all the patients in 12 months and showed a 50% reduction in readmissions in the first 30 days that for patients that were enrolled in care management. So in this case, it was remote patient monitoring plus chronic care management compared to patients that weren't enrolled at all. So the only difference with this cohort was that they were either enrolled or they weren't. And so the overall reduction in the first 30 days was what we had hoped for. It was actually more than what we expected. But I think what's even most impressive at this type of look back and data is that those reductions in readmissions were actually still maintained as much as 12 months later. So not only was this preventing that benchmark that we all look at is that first 30 days, those reductions continued on for the next 11 months. And so that really showed the impact of having these patients on a consistent program of either RPM, CCM, or both in this case. So, and in this case, just like the MercyOne, it wasn't just technology. It was a clear coordinated effort between the clinic itself and the cardiology group, along with remote care teams and having a very established workflow in place and identifying the proper patients that should be enrolled. So Teresa, when you see that reduction now in Cardiac Solutions, the zero admissions and MercyOne, how do you think, what do you think about that consistency? I mean, these are two different settings that we're discussing.
Yeah, I mean, I think it just reinforces that the model itself works. When you put the right pieces in place, a model like this truly does prove, added value. These organizations didn't look anything alike, as you stated, Paul. I mean, they were different markets, different patient demographics, different clinical staffing structures, yet the results follow the same direction, right? They all showed improved quality and reduction in hospitalizations, readmissions. So I think the model itself speaks for itself.
Yeah, I mean that's the common thread was the workflow, the clinical team's high touch clinical oversight. When you have this, you combine consistent monitoring with reliable specialists and escalations to the groups, you get meaningful outcomes, regardless of the environment or the group, as long as you keep those and maintain those consistently. So the MercyOne results weren't a unicorn, they weren't magic. They were the product of a model that works and that can be reproduced and deliver value not only for the providers, the health system, but also for the patients as well. So we touched on the clinical impact. I just want to touch a little bit about other outcomes that should be discussed, right? So we obviously had the readmission rates and reductions, but also what was the operational and financial output impact on the program. So for Mercy Heart and in some instance, in some way also the cardiac solutions, we had fewer emergency escalations, more stable and manageable workflows, even day to day. We actually saw less strain on the specialty heart failure team by taking some of those burdens off from them. And then the patients overall felt more confident managing their own conditions, more secure by their care. And all that led to the outcomes that we saw. So when you remove, constant fire drills, especially with a population like advanced heart failure, those fire drills equal to less last minute calls, less urgent visits, less hospital readmissions. Everything gets calmer and we can focus really on the care for the patient.
Yeah, and I think that shift makes a real difference for the care team. Nurses reported feeling empowered instead of reactive. When they're responding to structured escalations instead of a sudden crisis, the burnout drops, satisfaction rises. And critically, the specialist can stay focused on those clinical decisions, not on sifting through all that raw data. Having a dedicated monitoring team managing the daily surveillance allowed MercyOne heart failure specialists to step in when their expertise was needed. So that's when the heart failure programs really thrive, right? We want them to focus on the patients that are the sickest at that time, the highest acuity, and that need their expertise. And that's what really drove, the outcomes for this program.
Yeah, and operational stability translates directly into meaningful financial impact. So, preventing 81 readmissions in a 6-month span, you avoid a significant amount of high acuity spend. So this is good for the patient, but it's also good for the broader system. So we avoided hospitalizations and there was an immediate return on investment financially as well. We had fewer high acuity encounters, better cost trends and how you treat chronic disease. You are utilizing your staff to just focus on higher level needs and interventions and outsourcing some of that work, in this case to CoachCare. And you have a full care model that's actually supported through the reimbursement pathways and continuous monitoring. So it's a financial impact as well as a clinical one. So you take the chaos, like I said before, replace it with a structured, repeatable workflow, and the organization also benefits operationally, financially, and clinically.
Yeah, and ultimately, that's the real story here. Just like you said, Paul, I mean, it wasn't just fewer readmissions, it was a complete shift in how care teams functioned and how patients felt. So the clinical, operational, and financial gains are all moved in the same direction because the monitoring model was consistent and the interventions were timely.
Yeah, so this kind of leads us to a shift for 2026, right? There is a new model, ambulatory specialty model. So you might see another acronym, ASM, for this. So just to really briefly shift from the readmission study to now what's ahead for next year, I think this is shaping up to be a really important year for cardiology and heart failure programs. So the biggest one, like I said, is this ASM model. This is a mandatory program, so it's a 5-year payment model for cardiologists who treat at least 20 Medicare heart failure patients, and it will be these for this model. CMS is going to actually select cardiologists to be part of this model. It's not an opt-in situation. You are selected, and so they do expect that roughly a quarter of the country to eventually fall under this model. So under this ASM model, groups will operate in two-sided risk environments from day one. So it would be a payment adjustments ranging from -9% of the fee schedule to a +9%. So that's a big swing, especially where heart failure is such a variance and the cost is high. The way performance is measured is also shifting. So CMS is moving cardiology out of a MIPS traditional, the MIPS value pathway, and looking at quality, cost, interoperability, and coordination. So these are the core pillars of the programs that we just talked about, right? So it is aligned. And these participants will be exempt from MIPS during these years, but they will still be accountable for outcomes and care coordination and costs. So, this isn't something that's way down the road. It's here and it's starting very, very soon. Next year, CMS is going to identify those that are participants, and then the performance period is going to be the next 4 years after that. And then that payout period and the adjustments are going to be the subsequent 4 years to follow that.
Yeah. And what Paul is describing, that CMS is really saying is we want cardiology practices to manage heart failure proactively, continuously, and as part of a coordinated ecosystem. Everything about the ASM mirrors what we've seen in high-performing heart failure monitoring programs like the ones we just described to you. Early identification, fast escalations, that coordination is there, and preventing the avoidable acute events from happening. The model is built around the same levers that help MercyOne achieve that zero readmissions. So we're happy that we're actually in the forefront of this, that we have our program, our solutions set up to meet the needs of where CMS is going.
And where is CMS going? I think that there are some payment shifts for 2026 that are already going to take shape. So because of indirect practice expense reallocations, on average, we're going to see about a 7% decrease for payments for cardiology services within facility settings, but we're going to see a 5% average increase in non-facility settings. So that's also going to affect a 2.5% efficiency adjustment that CMS is applying to many of the RVUs that affect cardiology. So what they're doing is they're signaling that the specialty must deliver more value per dollar and avoid preventable high acuity episodes that are going to drive up costs. So those readmissions for heart failure patients are both, right? So CMS is pushing cardiology toward care outside of the hospital and data-driven decision making, right? And these models, like remote patient monitoring and heart failure programs that reduce acute utilization. Like we discussed, MercyOne's program, it doesn't just align with the direction CMS is heading. They're already operating in a model that CMS now wants the rest of the country to adopt.
Yeah, exactly. I mean, that's just another signal we're seeing from CMS, continuing to affirm that RPM and CCM are foundational components of chronic heart failure management. These include broader permissions and remote supervision, incident to care, and cardiac rehab. I think the message is clear here, that heart failure needs longitudinal, connected, proactive management. So exactly the kind of structure remote monitoring enables. And then when you couple that with CCM, PCM models, we're going to continue to see the outcomes driven in the direction that the case studies we just shared with you.
So what are the strategic takeaways for heart failure programs in general and the implications for the cardiology groups and the health systems? What this means is cardiology is being moved towards prevention and continuous oversight, not episodic intervention when you see the patient at a facility or see them in the office. And heart failure specialists in particular are going to carry greater accountability for readmissions, for the cost savings and coordination, whether they're been selected for this ASM model or just responding to fee for service pressures and models as well. So continuous monitoring, like we've discussed, supports required pathways for quality scoring, cost containment, and also patient stability. So it really hits all those buckets. And even cardiology groups or cardiologists not selected for ASM will still feel these ripple effects, right? So there's always a change in the fee schedule every year and a shift, right? It's a zero sum game. So where we take away, we add, and where we add, we take away. And so I think we're going to continue seeing that shift to support more of these models. This is what CMS is signaling, like Dr. Sieck has mentioned. Um, they're going the way that this MercyOne program was laid out. So when you put this all together, clinical results, operational improvements, the financial impact, the policy landscape, we're the model is here. It's repeatable. It works, and CMS is steering cardiology and heart failure towards these programs. And so, it asks the question for any organization that's treating heart failure patients is how do we take these learnings and insights and make them actionable in your own programs? And so, what did MercyOne do right? What did CoachCare do right in implementation? What is essential in those programs that make them a success? And what's repeatable? What can we replicate? And where do we know that the challenges are and make sure that we avoid those and don't stumble?
Yeah, exactly. So, what we want to share next are the practical lessons. So the pieces that made the biggest difference and the elements that have to be in place for outcomes like this to really happen. So when we look at across MercyOne and Cardiac Solutions and other high performing heart failure programs out there, the patterns are incredibly consistent. So there are foundational principles that made Iowa Heart monitoring succeed every single time. So first they started with their highest risk patient population. These patients often, as we said, have the most variability from day to day, the biggest fluid shifts, the narrowest margin for error, if we will. They're also the ones who benefit immediately from that daily oversight. Second, you have to build your workflow. And technology alone doesn't move the needle. So what drives outcomes is the pairing of continuous monitoring with that rapid, predictable escalation to the specialty team. So you're taking technology, the human oversight, and escalating it to the experts so that we can see these repeatable outcomes. And third, and this is critical, we need to focus on trends, not just those isolated alerts. So we do get alerts. We know when something has a one-off isolated, a vital that has triggered us, but we also need to pair that with the trends and patterns that are going on with this patient. So a single reading doesn't always tell the story. It's 3 days of subtle weight gain that starts to creep up that tells us a story. That variance in heart rate that we see the heart starting to work harder and the heart rate has gone up. So very critical to be able to identify those patterns or trends. And then fourth, keep onboarding simple. So the more seamless you can make this experience, no apps, no pairing, no portals, the faster you get reliable data and you get consistent patient engagement. And finally, dedicated trained clinical monitoring team. So if you put this workload on your clinical nurses, the program becomes reactive instead of proactive. MercyOne succeeded because the heavy lift, the daily reviews and documentation and escalations happened outside of their clinic. It happened with the CoachCare monitoring surveillance team. And that allowed their heart failure specialists to really focus on immediate interventions that were going to impact the patient's outcome, make a difference in whether they were going to be visiting the emergency room or the hospital.
Yeah, it's great and very important points. But all those teams also have to be on the same page and talking with each other. Consistent communication between those monitoring teams and then also the heart failure specialists and the providers is non-negotiable when you launch these programs. You cannot be successful living in silos. That's what we're trying to prevent, right? We want to connect the discharge from the hospital, the patient at home, and with their providers to prevent readmissions. And that's really the core of these programs. So developing, an escalation pathway that everyone agrees upon, and who it goes to and staying in their lane is really the foundation of these heart failure monitoring programs that we have seen.
Yeah, I couldn't agree more. Absolutely. So when you put all these elements together, high-risk patients, workflow clarity, trend-based reviews, simple onboarding, and a dedicated monitoring team, both on the CoachCare side and on the clinical side, that's when you see results like 0 readmissions. These aren't nice-to-have features. They're the essential building blocks for a sustainable heart failure program.
Great. So what is next, right? That concludes the formal presentation of our program, but we will have everything available as far as the details of the case study. If you'd like the information on the cardiac solutions data that I presented and the benchmarks that we referenced earlier, just let us know either through the chat or email afterwards, and we can send those out. Our doors are always open as well, and the policy changes regarding ASM and the changes starting in a couple years in the selection process for next year. I think it's really important to reach out and discuss what's the best program for your practice and your patients. And we're happy to talk that through with whomever is reaching out.
Yeah, absolutely. And I'll add that for any of you that want a deeper discussion, our next open office hours that I talked about when we started this webinar today will be in January 2026. You're all welcome to join, bring your questions, share what you've been working on. We're excited to learn more too and share everything that we're learning along the way. Most importantly, though, thank you for spending your time with us today. We were excited to share, these case studies with you, where we've come through this pathway and, what CMS is signaling to us. So what we will do now is open it up for questions. But again, thank you for your commitment to improving the outcomes for these advanced heart failure patients.
All right, thank you. Yep, if there's any questions, I'm going to look at the chat and see if I can see in there. And we'll open it up for any questions in Q&A. All right, I see one that I'm going to direct to Dr. Sieck. What was the biggest operational change MercyOne had to make for the program to succeed?
I think we kind of touched on this throughout this process. It was the multiple building blocks, right? So we had to make sure that we had things in place to identify the best patients. We had to create a workflow that worked well for their current system and offload work from a team that was used to doing everything. They had work overload, right? Fewer FTEs to do that. So we had to figure out the proper workflow. for them and for our team to make sure we had escalation protocols and standard operating procedures in place. And then I think simplified that onboarding. You know, we walked through these steps. It was just figuring out what are the building blocks, how does it pertain to them, how do we have to change what they're doing today to meet their needs so that they feel a part of this program because these are their patients. We wanted them to have their hands on those most acute patients when it was necessary, and let us filter out the rest of the noise and make sure that the patients are still well taken care of. So the process we walked through is exactly what we had to do at MercyOne.
Great, thank you.
Mhm.
What is the best way to motivate a patient to take readings daily? That's a great question.
Yeah, it is a great question. And that also, you know, is on our shoulders because it's not only just telling patients to take their vitals, it's building relationship and trust with them that this data is being used to drive a care plan for them, right? So it's not about just a blood pressure. It's about learning more about the patient, getting their vitals, explaining to them the benefits of the program and how their clinicians are using that data to drive a better care plan and keep them out of the hospital. Most of these patients, if you explain the why to them, they're more than happy to transmit their information, their data. They just don't understand the why in most cases. And so if we can explain to them that the benefits of the program are that we're an extension of their doctor and we have our eyes on this data coming in and it helps the provider and their clinical team really drive a care plan that works for them. It hits home to them when you say, you know, we know that, you know, you've been a frequent person to the emergency room or the hospitalization. We know that's your safety net and we want to provide a new safety net. We want you to be able to stay in your home and transmit data to your provider that, they can make timely interventions. And that's usually how we're most successful in getting patients to submit data, is just explaining the benefits of the program and how it's going to improve their quality of life and length of life.
Yeah, I'd like to add that, and then having reinforcement by the providers is key too, right? So when you do see the patient in the office, whether there's been an escalation or an urgent need, but just reinforcing that you see the data and it is connected to you in the practice, right? And then the patient knowing that the provider cares and wants to see this data goes a long way to compliance as well.
Absolutely.
All right, well, we'll wait to see if there's a couple more, but those are great questions. All right, I still have on our screen any contact information that if anyone wants to connect with us, email, LinkedIn. There are QR codes on the screen. We'd love to get connected and bounce ideas off and questions and continued conversation. You know, this is an ever evolving market and segment and delivery and changes every year from CMS and guidelines. And so always happy to talk through that and stay connected. So I'd like to thank everybody for joining. I know we delayed there a little bit on the start and sharing, but I think we got back on track. So thank you very much.
Thank you, everybody.